So I'm going to be doing my presentation on schizophrenia. I've learned that it's one of the most debilitating mental health disorder diagnoses. The prognosis, even today, is still considered poor. Walker, Kessler, Bellini, and Hodgman state that only 20 to 30% of those diagnosed with schizophrenia are able to live what they consider a normal life. And what they mean by normal is as evidenced by the ability to hold down a job and or live independently. One of the interesting things about schizophrenia is the fact that oftentimes patients, clients are unaware of that they have an illness. Schizophrenia impacts social and occupational successes. The consequences can be devastating for adult life course for the entirety of the adult lifespan. The psychotic features typically show in teens to 30s. That's when usually there's a primary first psychosis where there's a diagnosis. One thing I want to point out, in mental health counseling, we diagnose. We should take caution with multicultural clients due to things like normalcies of culture, such as in some cultures, witchcraft is something that's considered normal. Sometimes visual and auditory hallucinations. Certain religions believe that they can hear God's voice or voices, images of loved ones that have passed on. In some cultures, distress may take the form of hallucinations. So we want to be real careful to take into consideration multicultural aspects of the clients that we treat so as not to give a misdiagnosis. As far as historical content, as you guys know, I've been a registered nurse for a long time, so I found that some of the basis of the history of schizophrenia was really interesting, and I didn't do a slide on that, but I wanted to give you guys just a quick overview. I read a large research project slash paper that was written by Walker, Bellini, and Hodgman, and they gave a historical view of the etiology of schizophrenia. They found that behavioral symptoms that parallel schizophrenia has been recorded way back in images, pictures, drawings, back to Mesopotamia, ancient India, Greece and Rome, the Middle Ages, and Europe. Moving forward from the mid to late 19th century, psychiatrists began to investigate various types of psychosis. And what we know now and what they didn't know then was that at that time period, the most common cause of psychosis was actually tertiary syphilis, which is an infectious agent. Syphilis untreated goes into multiple stages, and that third stage of syphilis, they present with symptoms of psychosis. So they didn't know that at the time. So I found that really interesting. The first person to differentiate schizophrenia was Emil Kraepelin, and he called it dementia praecox, which meant dementia of the young. The term schizophrenia was first introduced in the beginning of the 20th century, and they named it schizophrenia because schizo means split and phren means mind. So they sort of thought it was a split mind. In the 1980s, psychiatrists began to emphasize positive and negative symptoms of schizophrenia. The positive symptoms involve an excess of idea and sensory experiences and behaviors, such as hallucinations, delusions, and bizarre behaviors. The negative symptoms involve a decrease in behaviors, like the blunted flat affect, the inability to feel pleasure, the lack of motivation. So I found that was really interesting. Now, on to my second slide. What's really quite profound still yet is the fact that the etiology of schizophrenia is pretty much unknown. There's three theories, and they have a lot of evidence for all three of these theories. As the slide says, inherited genetic factors, that's one of the theories. In fact, there are multiple genes, not just one gene, that have been identified post-mortem in patients with symptoms that differ from a normal brain. They've done adoption twin studies where twins were separated at birth or adopted and raised separately. And what they found is that there is a correlation in familial genes with clients that have been diagnosed schizophrenia. Prenatal complications, number 2. The later development of schizophrenia has been linked to obstetrical labor complications, specifically complications that impact the oxygenation of a fetus. So any kind of fetal hypoxia, or it can even be exposure to maternal infections during the second trimester of pregnancy, specifically influenza and rubella. They found that linked to later being diagnosed with schizophrenia. Third, postnatal brain trauma. It seems that there's a correlation or an increased risk for later development of schizophrenia if a person's had a head injury when they were under 10 years old. Purportedly, just mainly, they're finding that external stress and neuronal maturation issues influence the vulnerability for a person to later on develop symptoms of schizophrenia. Symptoms of schizophrenia. The main thing that I want to point out is, with diagnosing, we've learned through the course of this program that we always want to rule out medical conditions that might be influencing a person to have certain symptoms, and we want to rule out substance abuse issues that could be causing a person to have certain symptoms. So I want to point that out straight ahead. The symptoms of schizophrenia, as defined by the DSM-5, are delusions, hallucinations, disorganized speech, which would be loose associations, derailment, word salad, grossly disorganized or catatonic behavior, negative symptoms. And I want to point out again what negative symptoms are. Negative symptoms include like a diminished emotional expression, and you see that primarily like in the face, hands, body movements, the body movements and hands and face that would give an emphasis like I'm doing with speech. That's diminished with them. Also, negative symptoms would include decrease in self-initiated motivational activities, diminished speech, decreased ability to experience pleasure, decreased interest in social interactions. All those would be negative symptoms included under the diagnosis of schizophrenia. Also, the DSM-5 points out that the level of functioning in one or more areas is markedly below the level achieved prior to the onset of symptoms. Continuous signs of this disturbance must go on for at least 6 continuous months. 6 months. So, possible co-occurring disorders. I found Buckley, Miller, Leherher, and Castle identified the most probable co-occurring disorders as substance abuse disorders, depression, obsessive compulsive disorder, post-traumatic stress disorder, panic disorder, generalized anxiety disorder, and social anxiety disorder. I also want to point out that the DSM-5 labels certain specifiers that are associated with schizophrenia, and I found those quite interesting as well. The specifiers are first episode, currently acute episode, first episode, currently in partial remission, first episode, currently in full remission, multiple episodes, currently in acute episode, multiple episodes, currently in partial remission, multiple episodes, currently in full remission, continuous and with catatonia. And catatonia, however you want to pronounce that, pretty much is just a lack of reactivity to one's environment. So those are the specifiers that the DSM-5 points out. As far as court-mandated treatment, what I found in studies, and now that I live in Maryland, is I find that court-mandated treatment is often prevalent with mental health courts here. And I found a study that I noted down there at the bottom of my slide. It talked about mental health court in New York City. But through my internship side, I've been able to also have client experience with mental health court clients. And what happens is that if you go to court and you have misdemeanor felony charges and they suspect that it might be related to a mental health disorder, or the officers wrote down in their report, symptoms like, hallucinations, God told them to bust the door down. I had one client, that was his symptoms when he got picked up. He had broke into somebody's house and had told the police, God told me to do it. I heard voices and that's what was going on. So my point is, with mental health courts in major cities, if you have certain symptoms that they think might account for why you broke a certain law, they have you assessed by a mental health professional. It can be in the jail, or it can be upon as a condition of your bond. And you get the mental health assessment, and if you're diagnosed with a mental health disorder that the practitioner thinks may have contributed to the fact that you broke the law, then the judge orders, as part of your mental health court here in the state of Maryland, they have to call a certain person with the courts every day. They have to be compliant with medications, and they have to come to weekly counseling sessions. So what I found in experience, and it was also noted in this reference there that I found, often clients can be resistive to treatment. Again, like I said, the study in New York showed that clients ordered into outpatient treatment had reduced hospitalizations, and they had increased medication compliance. I've had one client throughout my internship. I got him ordered from mental health court in May of 2017, and actually he's done very well, has been compliant with medication, no hospitalizations, no further legal trouble, and I was able to write a recommendation to the court, with my supervisor, and he actually just got released from mental health court last month in November, or I guess that's this month. So he'll have 2 more years supervised probation, and he has to continue a minimum of bi-monthly counseling sessions throughout the term of probation. In those reports, we have to say that he's continued to be compliant with his medications. And so I think that mental health court, for people, with a mental health diagnosis, I think that should be an option for them because, from what I've seen, the client that I'm speaking of, he had schizoaffective disorder and had never knew, why he was having the mood fluctuations, why, he was hearing voices and etc. So I feel like mental health court and court mandated treatment can really be a good thing, because I believe that there can be a lot of times when that should be called for. That's just my opinion. Okay, next slide. Treatment modalities. So I guess the main thing that I want to point out here is, as always, if a client is a risk to theirself or others, particularly with schizophrenia, hospitalization during acute psychosis would be a priority. I want to point out that suicide is the leading cause of death with schizophrenia. So, that needs to be assessed primarily. The treatment modalities, pharmacological treatment is one of the priority treatment modalities for schizophrenia. And what I've found is that there's two different types of pharmacological treatment. First generation antipsychotics, and those would include, as written here on the slide, actually I won't even go on and read those. You guys can read that yourself. Pretty much the main first generation antipsychotic is Haldol, and the issue is second generation antipsychotics are now preferred over first generation antipsychotics. And first generation, of course, back when, that used to be all that we had as far as to give a client with schizophrenia. But the side effects are very great, which is why the second generation antipsychotics are now preferred. The common side effects of first generation antipsychotics are extrapyramidal syndromes, pseudoparkinsonism, which is just characterized by slowness, tremors, shuffling gait, rigidity, and loss of body movements. Another side effect is uncontrolled sustained muscle contractions, restlessness. Tardive dyskinesia is another big one, and it's like irregular twisting, writhing body movements, and these side effects are uncontrollable. So I think psychiatrists, from what I've read, I wrote a couple references down there on the slide. From everything that I'm reading now, the second generation antipsychotics are preferred due to the lessened side effects. Second generation antipsychotics, you hear probably more of these now: Abilify, Clozaril, Fanapt, Geodon. I see that a lot at my internship site. Invega, Nuplazid, Risperdal, Seroquel, Safras, Vraylar, and Zyprexa. Let's see, next slide. Also, psychotherapy treatment, of course, which is very, very important. What I've found from the research that I've read, individual therapy, family therapy, cognitive behavioral therapy, and behavioral therapy are the preferred psychotherapy treatment interventions. Okay, so interventions and treatment strategies. Pretty much we want to engage the implementation of healthy coping mechanisms. Teach healthy coping skills. We want to engage the client into learning healthy, appropriate social skills. We want to provide psychoeducation to the client and family members, caregivers. We want to teach stress management techniques. We want to do modeling, role-playing, implementation of target behaviors that are practiced over and over with behavioral therapy and conditioning. That'll be very important. Also, what I found, I have several clients diagnosed with schizophrenia that I see weekly through my internship site. And from a CBT standpoint, I feel like it's important to respect and acknowledge the client's reality, particularly when first treating a client with schizophrenia. I think it's important not to dispute the client's hallucinations and delusions until you've established that rapport and that trust, that therapeutic alliance with the client. I think it's also important, and I've found in the research, it's important to treat symptoms of distressing psychosis by changing self-talk. Recognition of those cognitive distortions once you've built up that reality. I have a 15-year-old client, and it's been important for me to validate or acknowledge that the things that he sees and hears are real to him. But if I were with him, I wouldn't see and hear the same things that he does. So I feel like it's important to validate and respect, acknowledge, I guess not validate, but acknowledge the client's reality with schizophrenia, and then later use CBT to treat those symptoms that are distressing to them, and to engage them in being able to set boundaries on their hallucinations and delusions, and to be able to change their self-talk. Important assessments in schizophrenia. First of all, as I said, suicide is the #1 cause of death with schizophrenia, so it will be very important to do a suicide risk assessment. We want to know, are they an imminent risk to themselves? Also, a homicide risk assessment. Are they an imminent risk to somebody else? Are they naming that person? Do we have a duty to warn, as set forth in the precedented case, Tarasov's case? Do we need to warn somebody? And again, with suicide homicide assessment, do they need to be confined? Do they need to go to the hospital? Do they need to be in an inpatient psychiatric ward? So those are the two #1 assessments. Also, along with the homicide risk assessment, suicide risk assessment, we want to do a lethality assessment. Do they actually have the means to hurt themselves or others? Do they have a gun in the home? Does somebody else in the home have a gun, or do they have knives? Are they on their person frequently? Those are things that we need to know. Another assessment is the MMPI-2. It's 500 true or false statements, 500 something, and pretty much it shows personality traits. It can give insight into psychopathologies. It allows us to evaluate cognition. I also listed on there the NEO-PI-3. This is a personal inventory that measures 5 domains of personality. So that can be, again, very insightful as to what the client's thinking. Also, there's something called a clinician-rated dimensions of psychosis symptom severity. And in the DSM-5, you'll see that under the diagnosis of schizophrenia there in the middle, it explains pretty much what that is, and it's the ability to rate schizophrenia on severity. And what the clinician does is they take the consensus from both the client and even family members of the symptoms that the clients had over the past 7 days, and they rate it 0, none present, to 4, which is symptoms are there and they're severe. So it's a severity rating scale that's done by the clinician. Another thing is a brief psychiatric rating scale, and that is a 1 to 7 rating, 1 being not present, 7 being extremely severe, of 18 symptoms. And again, this is done by the clinician, and it rates things such as suspiciousness, hallucinations, grandiosity, mannerisms, and it can ultimately be measures that can be assessed to see if our clients are being responsive to our treatments. Another one is the brief negative symptom scale. It's more schizophrenia specific. It evaluates communication, emotion, affect, social drive, and activities of daily life. Again, I've got some references down there if you guys are interested in reading some articles on those assessments. I did find one that I didn't put on the slide because I think it would be an assessment that one would need, definite in-depth training on. It's called the Wisconsin Card Sort Test, and it is really interesting. It's a test where you show the client cards. It's considered schizophrenia specific. Again, it measures abstract thinking, working memory, problem solving strategies, and it's very interesting. Again, it's called the Wisconsin Card Sort Test. Obviously, one would need intensive training to know how to not only give the test, but how to assess, the answers. Obviously, there would be no right or wrong answer on that sort of test. So that was interesting. Theoretical interpretations. From what I have come to understand, psychoanalytic theorists believe that schizophrenia, the symptoms of schizophrenia are a regression to the oral stage. And just pretty much the requirements of the id is the causative factor of the symptoms of psychosis. Very interesting. Social learning theorists believe that the lack of ability to attend to the social environment is what causes the disturbance in thought processes, affect, and social roles. Experimental theorists have decided or have a stance that schizophrenia is not an illness, but rather behaviors and experiences that are falsely labeled. We're falsely labeling these people. So that's interesting. Case study. I'll just pretty much let you guys read it, but person, this is based pretty much on, a fictitious case study. Person presented after a 7-day inpatient psychiatric stay, divulges auditory and visual hallucinations that have been occurring since age 14, voices that are commanding in nature, shadow-like people. He believes that his biological father, whom he's never met, may be a famous person. He presents with affect that is blunted with a lack of emotional expression. He expresses that he has little to no interactions with others on a daily basis in home and school settings. He admits to a lack of interest pertaining to events that occur around him in school and home settings. Appears unkempt. Expressive gestures absent. Psychomotor activity slowed. Clients, as he speaks, he's sometimes the things that he say are unrelated to what the clinician is saying. Divulges difficulty at school, knowing whether hallucinations are true or false. Can't figure out which voices are really talking to him. Obvious marked impairment in home, school, and self-care areas, which is a change from the previous level of functioning as self-reported by the client and client's family member. He's been, again, having these symptoms for the past year and a half. So the diagnostic impression would be F 20.9, schizophrenia, Z 55.9, academic or educational problem, Z 62.29, upbringing away from parent. Short-term treatment plan. I'm just going to go over it as I put it on the slide. Need to identify and foster healthy relationships. The goal would be client will build rapport and maintain therapeutic relationship as evidenced by participating in 3 out of 4 counseling sessions per month for 180 days. Another area to be addressed is manage hallucinations and delusions. And the short-term goals right there. I won't read it to you. The next area to be addressed will be manage mood and general stressors. Again, the goals right there beside it. And medication management. As I said, as far as treatment modalities, one of the most important things research shows is that we want clients to have medication compliance, medication management services. Let's see. Okay, that's my reference page. I want to say also what I found from research is the duration of treatment. Obviously, schizophrenia is a chronic mental health disorder. A lot of times it doesn't seem like the prognosis is very good. I want to say that obviously managed care organizations and insurance companies are going to mandate what the duration of treatment can be. The ideal goal would be that the duration of treatment would be until symptoms of schizophrenia are decreased and no longer impair and interfere with the client's daily functioning. That would be in a utopian world, but obviously we know that insurance will mandate treatment. There's my second reference page. I also wanted to tell you guys something interesting. Schizophrenia, as I was doing this project over the term of the semester, and because I have quite a few clients at my internship site with that diagnosis, I've become very interested, in schizophrenia, the symptoms, what they are, what I can do to help make a difference in these people's lives so that they can be their most optimal version of self, be restored to their best functioning person. And I wanted to tell you guys about 2 TED Talks. The first one is called Voices in My Head by Eleanor Longden. And I will provide the links here in this post so that you guys can listen to those. They're short. Interesting, Eleanor Longden is actually diagnosed with schizophrenia herself between her first and second semesters of college. As an 18, 19-year-old kid, she began having active hallucinations, voices. And what she found after much treatment is that the voices to her seem like a meaningful response to traumatic life events. She found insight into solvable emotional problems, and she believes that hallucinations are actually a person's survival strategy. She learned to interact with the voices in a meaningful and assertive way. She went on to attain her master's degree in psychology, and as a person diagnosed with schizophrenia who is able to work, live independently without medication, she believes as practitioners that our question should be, what's happened to you, not what's wrong with you. So again, that TED Talk is called Voices in My Head. Second one, and then I'll close, is called A Tale of Mental Illness, and this is by Ellen Sachs. Again, this is another person that's been diagnosed with schizophrenia, and she gives an interesting talk on her view of hospitalizations and restraints. She had graduated from Yale Law, went off to enter into the job force on her first job, and she got told by, I guess, the owner, the senior lawyer of the firm, that the job would be closing. And she became symptomatic at that time with acute psychosis, got diagnosed with schizophrenia. She now is, again, fully functional. She works. She teaches at University of Southern California Law School. She believes that one of the primary reasons that she's able to be independent and fully functional, by her quote, is that she is compliant with medications. So that's two different clients that have been diagnosed with schizophrenia, both independent, both able to work jobs. One is not medicated and believes that her hallucinations are insightful and she should respect them and set boundaries. The second person believes that medications are necessary to be fully functional and independent with a diagnosis of schizophrenia. That second one is called A Tale of Mental Illness. I hope you guys have been able to learn a lot. I sure have in doing this presentation and doing the research for this. And that's all I have. Have a great day.